Alright guys, how is it going? Hope renal was splendid, renal and GI. Heard lots of good things about the test. So, we are now starting respiratory. Blue wheel, go away please. And respiratory was not my most favorite subject, especially respiratory physiology, but maybe it will be yours. So I will try to speak with the same enthusiasm that I did with neuro, but it's not nearly as cool, so I'll just have to fake it. This first lecture is going to cover the anatomy, the concept of dead space, and then minute ventilation. Hopefully I can get this recorded before the bachelor tonight. Okay, so be familiar with these two zones. There's a conducting zone and a respiratory zone. The conducting zone is basically what we think of as just the airways. I'll show a picture of it later. Air goes in and out of the conducting zone. This is really important here. Mucociliary escalator. And basically, when you hawk up a huge loogie, that's because there was, bacteria and debris that got into our airway, and then it was sent back up against gravity via this mucociliary escalator, and then it comes out in the morning in the form of a big loogie. It's lined with smooth muscle, and why is that important? Well, remember, the little neuro review, and just FYI, I think I might include one question from each previous system, either in my questions or as a bonus question. So one neuro question, one renal question, and one GI, and it'll be related somehow to the respiratory system. So that's what I'm thinking. So don't freak out, it's not cumulative questions, but I'll probably put them as bonus questions or something. But speaking of that, smooth muscle has parasympathetic innervation and sympathetic innervation, right? The parasympathetic innervation is, there's M3 receptors that line the smooth muscle, and what happens when acetylcholine binds? Do you guys remember? Say it in your head. Give you a second. You get bronchoconstriction. Right? The airways clamp down. It's because there's contraction of that smooth muscle. M3 is what G proteins couple to M3. GQ. Okay. Sympathetic innervation. Oh crap. The beta 2 receptor. And what happens? Let's say when norepinephrine binds there. Dude, getting pissed. You get bronchodilation. And, that's why you give beta agonists for asthma to open up the airway. Just a little review. But that's, on the conducting zone. The respiratory zone is where gas exchange occurs. And because they're capable of gas exchange, this area is lined with alveoli. The alveoli are lined with elastic fibers and epithelial cells. And down here, whereas up in the conducting zone, the mucociliary escalator dealt with the debris accumulation, down here, these alveolar macrophages deal with the bacteria and debris that get through. And something like in less than 5 microns or micrometers that get down to the bottom of the respiratory zone. What do I want to say? Oh yeah, epithelial cells. So these epithelial cells are specialized cells known as either type 1 or type 2 pneumocytes. Type 1 is squamous and type 2 is cuboidal. And speaking of, these are the alveolar cells. These here, these long ones, are all type 1, and they kind of have like, I don't know, the pseudopodia or whatever it's called that stretch all along the area. They actually cover 95% of the alveolar surface, and that's important for something that does gas exchange, right? They're squamous, whereas type 2 are cuboidal. This is type 2 here. They cover a lot less of the alveolar surface, but they have two very, very important and high yield functions. Okay, one, they secrete surfactant, and surfactant decreases the surface tension of the alveoli, and that allows for more compliance. That also allows for I'll call it the stabilization of small alveoli, because, you know, I'll draw it up here. Large alveoli generally are pretty stable, but small alveoli have a tendency to collapse, and surfactant allows for the stabilization of these smaller alveoli. Number two, type 2 pneumocytes have regenerative capacities. So kind of think of them as, I don't know, sort of stem cells for the pneumocytes. I think they can regenerate both themselves and they can replenish type 1s also. Okay, here's a couple pictures of the conducting zone versus the respiratory zone. So the average tidal volume is around 500 ml. So of that 500, 150, approximately per inhalation goes to the conducting zone, and 350 goes to the respiratory zone, which is good. It means more air. More air means more oxygen is being brought to the site of gas exchange, and more oxygen can get into our bloodstream. So the reason that seemingly smaller structures can contain more air is because there's this branching that occurs. See this right here? It goes from 32 to like 6 times 10 to the 4th. And I've always had trouble conceptually understanding this, but basically there's a bunch of parallel branching that happens, and that allows for like an exponential increase in the surface area. So, which is good, right? Because more surface area means more alveolar surface, which means more gas exchange. That's the reason when you take a breath, say of 500 ml, that 350 goes down to the respiratory zone. Be familiar with the terminology here, because there are different pathologies that affect different areas. For instance, emphysema is a disease of the alveoli, and then something like chronic bronchitis is a disease of the small airways, or the terminal bronchioles. And they love asking pathophys questions about this layering. We'll get to this picture later on. Okay, so just this is like the gross anatomy. So this is, what you'll learn in anatomy. Trachea branches into right and left main stem bronchus. Then you get another division. You get division into bronchioles, then terminal bronchioles, and then respiratory bronchioles, alveolar ducts, and alveolar sacs. So the terminal bronchioles do not participate in gas exchange, okay? It's important to remember. A lot of people get confused there for some reason. But the only bronchiole that can participate in gas exchange is the respiratory bronchioles. This is kind of a nice clinical break. You put your stethoscope and listen to somebody's lungs, and you can hear something called rales or rhonchi. Rhonchi is kind of just like low-pitched wheezing. you'll hear it in, or that it's a large airway obstruction. So, anything from here to here, obstruction in the airway. These are examples of diseases you might hear it in. And then rales, you'll see crackles and question stems, are sounds due to the opening and closing of the alveoli. So that happens in this area. So there's this layering, this compartmentalization of the respiratory tree, and there's different pathologies that affect each area, and then there's different, clinical exam outcomes that you can hear from those pathologies of each area. Bibasilar crackles. If I had $1 for every time I saw that on a test question, all that means is the alveoli is covered in fluid, and usually bibasilar crackles means like heart failure, because the fluid's getting backed up and kind of soaking the alveoli and compressing it. You'll also hear crackles in pulmonary fibrosis, ARDS. This is from Dirty Yosemite video. He has a really good mnemonic: rales in the tails, right? And then rhonchi in the bronchi. So that's a good way to remember it. Histologic anatomy. This is so annoying, but I would recommend drawing this out or something so that you know the different characteristics of each zone. There'll probably be some type of test question on this. Oh yeah, and also definitely test question over that. So in the trachea and bronchi, and I put a picture here beside it to keep you oriented. You have cilia, goblet cells, basal cells. These goblet cells right here are important because they secrete mucus, and during chronic bronchitis, especially from smoke irritation, you can get something called goblet cell hyperplasia and or metaplasia, and that means these are just dividing, and they secrete these thick mucus plugs, and that causes the obstruction in chronic bronchitis, and that's why the people hawk up massive amounts of loogies. There's different type of epithelium throughout, so it's really annoying, but I'm going to tell you to know it just because you just got to memorize it, I guess. There's pseudostratified ciliated columnar, and then it goes to simple ciliated columnar, and then respiratory epithelium, which I forget what that technically is, but I'll get back to you. What else? Capillary. I think that's all I want to say there. Obviously, there's cartilage in the trachea, right? You can feel that on your neck, but then that starts to disappear when you get down into these divisions. This is a good table that sums it up, and several of these slides I took from Dr. Tom Curtis, so you'll probably see them again next year. But it's really important to know all three of these differences. Maybe Dr. Meek has already tested you over this stuff too. I don't know. He loves these questions too. But you know where each of these stop appearing, basically. So cilia, for the most part, stop appearing, the conducting zone. Some remain in the respiratory bronchioles. Smooth muscle stops appearing for the most part here, but then you have a little bit that remains. And then cartilage, for the most part, stops appearing at the trachea. Okay, so this concept of a dead space. Dead space is basically air that you breathe in, but that does not participate in gas exchange. So it can be divided into anatomic dead space or physiologic dead space. An anatomic dead space is something that you can actually visualize. It's from, you take a breath all the way from the nose or nasopharynx down to the bronchioles. And remember that picture where it was like 150 up top in the conducting zone? That's sort of how I picture it. It's the air that is kind of the last air in when you take a breath in. So it stays up top. It's like last air in, first air out. Okay, so that's anatomic. Physiologic dead space is kind of more abstract, but it's made up of the anatomic plus the functional dead space. So functional dead space is basically air that makes it down to the respiratory zone, right? But for some reason does not participate in gas exchange. So as you can imagine, normally in a healthy person, these two things would be equal to each other, because the functional dead space will be very small, because most of the air that makes it down to the respiratory zone is going to exchange its oxygen for CO2, right? But when you get pathologies, you get an increase in functional dead space. And there's a formula on this next slide that shows how to calculate that in pathologies. So this is the formula. VD, volume of physiologic dead space, equals the tidal volume times the PaCO2 minus PeCO2 over PaCO2. Annoying. I don't know if I'll ask you equation questions, but this is, I always remember this, taco, pico, taco, paco, pico, paco. It's kind of nice mnemonic, but taco, paco, pico, paco. And yeah, I don't want to get into it, but that's the formula. It's just giving you an idea of what you'll see in the future. It's important because, well, they say it's important, but equations are annoying. But if you do calculate that somebody has increased physiologic dead space, then that indicates there's a portion of air that's making it down to the respiratory zone that is not participating in gas exchange. So there's something going on that's not good. So this is like what I talked about earlier, like a healthy person. VD should be very small or close to zero, and that makes sense because the amount of CO2 that you're expiring or breathing out equals the amount in arterial blood. If this would be a situation, this person would probably be dead, because that means no gas exchange. Because if P equals 0, then that means you're not breathing any CO2 out, right? And in order for you to breathe CO2 out, you have to undergo gas exchange. PE less than, I don't know what that is. This is Dr. Curtis's slide, so we'll move on. This is an intro to a couple more equations. And again, if I'm going to ask you like a specific equation question where you have to calculate something, I'll let you know. These two are like pretty easy though, so to conceptually understand and to calculate. So ventilation rates, all it is a volume of air moved into and out of the lungs per unit time. So in the case of minute ventilation, it's the amount of air you're breathing in per minute. And what that is the tidal volume, and you'll know what that is after next lecture, but all it is just the normal breathing in and out, when you're not exercising, when you're not stressed, just normal, like in and then out, in and out, and that's tidal volume, and that's normally 500. So all it is tidal volume times the respiratory rate. And a normal respiratory rate is 12 to 20 breaths per minute. So 500 times 12 means you're approximately breathing or ventilating 6 liters per minute. Alveolar ventilation is telling you the same thing, but it's correcting for dead space. So remember, of that 500, there's a portion, on average 150, that does not participate in gas exchange. And remember that most of that air stays in the conducting zone. That's that last air in, first air out phenomenon. So all it is just the same exact formula, but you're subtracting the dead space. So 500 minus 150 times 12. This is a more accurate representation, which is why it's called the alveolar ventilation. Okay, which of the following lists only structures that compose the anatomic dead space? So anatomic dead space is all the way from the nose to the bronchioles, right? Terminal bronchioles. So it's not A, because that has respiratory bronchioles. It's not B, because that has alveolar ducts. It's not C, it has capillaries and respiratory bronchioles. And it's not E, because of the same thing, so it's D, anatomic dead space. Okay, which zone contains cilia? So remember that mucociliary escalator, which zone it was in? Conducting zone. Okay, which of the following structures directly participate in gas exchange? Not terminal bronchioles. Remember, only respiratory bronchioles can participate in gas exchange. It's not type 2 pneumocytes, but what are two very important functions? Surfactant production and regenerative capacity. It's not physiologic dead space, because remember that is the volume of air that reaches the respiratory zone but does not participate in gas exchange, and you usually will see this in pathological conditions. It should be roughly equal to 0 in a healthy person, healthy people. And answer is type 1 pneumocytes that do gas exchange. Alright, we will go over this next time. And enjoy your Monday night.